and you can upload on Canvas so that I can see that you have uploaded the courses. And for those of you who are not sure which course to take and have difficulties in logging in, I will be here today after the course, so just come to me to double check whether the course that you have registered to is the correct one. Do you have any questions on that? No questions. Okay, good. So today we'll go over the concepts of evidence-based practice, and we talked about it last week. Bless you.
Sorry.
It's okay. So we talked about it last week a little bit, how long we envision our dental careers to be, and we had it as short as 10 years and as long as forever, right, until you can work. But what I would like to ask you today is our dental career path, whether you are in the DDS program or in the dental hygiene program, is really diverse. It's not that everybody will go into private practice, but let's see how we are in this class. Who of you would like to go into private practice after graduation? Can you raise your hands? Okay, good. Who of you would go into academia or do some more advanced training or go into research? Raise your hands. One. Okay, good. Who is with the military or would like to go into some kind of public policy, administration, venues? Depends. Okay, not sure. Or are there any other pathways for you to pursue? Not really. So most of you, that's interesting. Most of you would go into private practice and practice. When we look at the statistics, just nationwide, most of our graduates, 90% would like to go into private practice, and 10%, so out of 10, you usually have one who would like to go either into academia, would like to go to join the army or the military, or would like to do something which is associated with public health care. So there are many pathways available, but since most of you, or except for one, are really interested in going into private practice. What happens when you go into private practice? That will be pretty much next year, right? Well, what do you expect your daily routine to be? Clinic? All day. So pretty much patient care, interaction with patients that you will be doing on a daily basis. So right now you're sitting in your chairs and get all the information put into, whether you like it or not, and somebody's talking to you about how to do this, how you should evaluate this and this. But after 1 year, next year after graduation, you will be pretty much very independent and make your own choices and decisions about the service that you're providing to your patients. So that's a little bit scary too. You really have no one to really at that time to ask, oh, how about this, how about this. You will probably call some of your colleagues or call some of your mentors or teachers here to ask for advice, but pretty much you are on your own to provide that patient service that you will be doing. And when we are talking about service to our patients, when you make your decisions on what kind of treatment you will be providing, what do we have to consider? What do you consider right now when you make choices about your patient? Can you look at the health history, standard of care, which would be what? Ethical standards. Good. What else would you look at? Patients. Who said that? That's Lucille. Lucille. Patient's opinion. Very good. And
everything, the case.
The case. But when we would look into, you've heard about evidence-based practice, right? We base our decision-making or decisions on evidence-based practice. What are the three components of evidence practice then? Evidence-based practice. Yeah, so patient opinion is a big one, and here the patient's values. So all the decisions you are making, it's not, oh, this is the way to do, this is the standard of care to do it. You also have to listen to your patients, because all of your patients have different values and have different opinions. So you have to really respect those opinions. You cannot just say, this is the way to go. So in making decisions, you will have to listen to your patients and incorporate them in the decision-making process. So patient values is a big component of evidence-based practice. Bless you. And then, what about your expertise? Are you going to incorporate that in your decision-making as well? I think so. If there are many different ways to treat a patient, and you have been trained in one specific way to do, then I think you will be more comfortable in treating the patient, for example, with option 1 that you have been doing for a long time, rather than going for option 2 where you think, I'm not that capable or not familiar with that treatment option. And sometimes that option 3, for example, might not be even available to you because you are not having these equipment or tools to provide option 3. So out of the different options that you will have available, you will take into consideration your clinical expertise as well. And then what is the last component of evidence-based practice? Yeah, external evidence. External evidence as it is out there in the literature. So where is the literature? Online. And it's everywhere. It's online, Google, everywhere. But you have to make sure that the external evidence that you're looking for is reliable and is accurate. Because out of the information that is out there, there's a lot of information, but you will have to make the decision whether this information is reliable, is based on evidence, or whether it's just an opinion of somebody who uploaded it on the website. So let's take an example. A patient is asking you whether brushing with charcoal will whiten their teeth. And there's a lot on the website. There's a lot online about charcoal and your patients. So you have access to external evidence, but so does your patients. So they have access to these external sites as well. But when a patient would ask you, is charcoal effective in whitening your teeth? What would you tell your patients? depends. And this you will pretty much encounter every day on a daily practice. Next year, your patients will ask you a lot of questions. They will not come with questions that you expect them to ask. They will just come out from nowhere. But let's assume a patient came in and asked for, would you recommend charcoal, just slurry charcoal for tooth whitening? Good. I don't know. I saw it on the internet that the charcoal is effective in tooth whitening. But would you are my dental hygienist. Would you recommend me to take those to use this?
No, at the moment, because I don't have any evidence yet to back it up. I don't want to recommend something until I have proof. So at that moment, if I
Do
don't
you need the proof? Do you have to create proof for everything that you are providing?
I want to provide like support for me to recommend that to the patient if they ask.
So pretty much, basically, you don't know,
Yeah.
right, whether
So
it
I
is
can
effective
say-
or not, right? So then it's probably better to say I'm not sure, right? But let me look up what the evidence is about charcoal tooth whitening, correct? Right? So what about what's your name?
Adrian,
Adrian, how would you respond to your patient asking for charcoal?
I think I would basically say the same thing in that I would much rather recommend something that there's evidence for, and that it benefits your health. But right now, I do not have that information, so that I need to research it on my own. And when I come back with an informed answer, I will let the patient know.
Okay, so I think we are pretty much a little bit on the consensus that based on the question, we are really not sure. I really have to admit, I really don't know. I am not sure what the evidence tells about charcoal tooth whitening. So I will look at it, look up and do some research. And then the next time when you come back, right, to my practice, I think I will be more confident to tell you about it. Correct? We all agree on that response? Can we raise our hands when we...
That's
If
happened
you already-
before. Like when we go, that's what they tell us too. They said we'll research it.
Yes.
Doctors always tell you
Uh-huh.
that. We'll
So
research it.
that's what you have been told,
Yeah.
and that's what you're going to do, right? Okay, so patient leaves. Patient leaves, and then you're done with your patient care. So at 5 o'clock or 5:30, what do? Go home. I'm tired. Forget about what I told, but I will just rest. And then you rested. And the schedule after 3 months or after 6 months, it shows the patient. The patient is coming back. I have to look today. I have to tell the patient something, right? I cannot say, oh, sorry, I didn't have time to look it up. I'm not sure. So this is the time that you have to really go back and do the research. How would you approach the research? How do you do the research?
I will.
Yeah, I'm asking, how do you do the research? What are you going to do?
I just go look up information. And
Okay,
filter.
let's raise our hands so that then somebody can. Okay, and this is
Sandra.
Sandra,
I would start with Google Scholar
Google Scholar.
and look for something that's previewed,
Uh-huh.
if anything is there,
Uh-huh.
and just check the source
Uh-huh.
and to support this information they have and all the research they follow.
Okay, so that's good. So Sandra is going to start with Google Scholar, not Google, but Google Scholar, which has a little bit more of those scientific information, and would look up whether there's some research or evidence to support or not support the use of charcoal. So, a core attribute of evidence-based practice as we move into this is the ability of you really to locate good evidence and then analyze. And it's not just locating, you have to think, is this really good information that I can convey to my patients? And then you have to be able to incorporate it into your patient care. And this will pretty much happen throughout your, they say, 30 to 40 years of your career. So it's an important aspect. And today I would like you to give some information on being more confident in analyzing those different sources and different articles that you will be reading, because you will be doing a lot of reading and you will have a lot of continuing education to keep up with the information that is changing and is being updated each year. So the case survey that you took on the first day of class last week had really 4 components. It looked, so case stands for knowledge. It looked at your knowledge of evidence-based practice and the attitude you're having towards evidence-based practice. The X is what type of sources you access on a daily basis to look for information, and the confidence that you have in interpreting and analyzing the results of those articles that you're reading. And in the class, the dental hygiene class of 2017, they looked at knowledge, the attitude, the access, and confidence intervals of dental hygiene students and dental students at the beginning of the course as you took the exam, and at the end of the course. And they compared the pre and post, looked how this course specifically influenced or was effective in increasing the knowledge, increasing the confidence, and also shifting the attitude towards a positive direction. And I mentioned to you before, so all of you will be completing a research project in the fall, but some of our students, they go really beyond, and out of the data and the project that they have been completed, they write up a manuscript submitted to a peer-reviewed journal. And this group, the names you probably will not recognize, but Victoria, Melissa, and Stephanie, who are now all dental hygienists practicing in different areas. They submitted it to the Journal of Dental Hygiene, and their manuscript got accepted, and it is now published in a peer-reviewed journal. So this is just to show that you can really go beyond. It's not just carrying out your research project. By publishing this comes a public domain, and all of you, just if you type in evidence-based practice, somewhere this article will pop up, and this knowledge that they achieved through their research project can be shared. So that's really the beauty. It's not only carrying it out, but being able to share the knowledge that you have acquired during this course. When you're looking at, so I have been doing this since 2017. So the class of 2017, at the beginning of the course, in knowledge, there are 10 knowledge questions, and they scored, the average was 26 points. Class of 2018, average 18. 2019, 20. And this is your class. right? So at the beginning, the scores that you had for knowledge was in the 20. Mean was about 20 or 19. So out of the 10 questions, two were correct. That was the average that this class had. So the knowledge on evidence-based practice, there is really room, a big room for improvement. And when we are looking at these questions, question 1 to 10, just breaking them down into the questions, none of you got question 2 correct. So there was 0. And that happened with the class of 2019 as well. So this seems to be a tricky question. 2018, I think just one student got it right. And this shows me where your weak area is, where you're strong, where your strength is. So let's go through these questions a little bit again. Question number 1. Published reports on treatments can be ranked with respect to the strength of the evidence. Which one of the following is the most correct statement with respect to ranking of evidence? And the ranking of evidence is very important, because when you talked about external evidence, you said you're going into Google Scholar, so you're looking at different websites. And the sites that we should really look into, which should be our first choice, the specific sites, our librarian, Ms. Tamaris, will come in next week to navigate with you through different websites and the websites that are most appropriate to really look for the evidence. So I'm not going to mention PubMed or which sites you should look into, but this is asking about the rank of evidence. And when we are talking about the rank of evidence, it will pop up later in my presentation. What did you see in terms of rank of evidence? Are you familiar with the pyramid that gives you the rank of evidence? So for question number 1, you would think that expert opinion is a good source to look for, correct? You're searching for expert opinion. Expert opinion is the opinion of your teachers or somebody who is very knowledgeable about that topic. You would think that this is one of the highest criteria or the higher steps, but it is. Expert opinion is the lowest level of evidence because it's very subjective. It can be very misleading. So if Dr. So-and-so, who is really a knowledgeable expert on this area, we would still consider it as low evidence because it can be very subjective and misleading. I think that was very tricky, so that many of you got it wrong. But let's look at number 2, where none of you got it correct. In judging the quality of the dental literature, which one of the following is the highest level of evidence? Do you remember what you said? Most of you said that case series articles that have been published in a peer-reviewed journal, such as the Journal of Dental Research, is the highest level. Do you remember? Do you recall? Do you remember the questions? And what you just... So case series that have been peer-reviewed articles are very good sources because they have been filtered already. But having an article published in the Journal of Dental Research does not necessarily mean that it is the highest rank of evidence. The highest rank that we usually say are the Cochrane reviews of an oral health topic. Have you heard about Cochrane reviews? Not really, right? And I think that's why all of you pretty much missed this. Cochrane review, we will be talking about this a little bit later. Number 3, many of you got this correct. If you were conducting a PubMed search, what would be the least effective? It would be least effective to search by year. And then let's go to some question number 8. I think only one student got it correct. Which of the following is the most appropriate study design to evaluate the efficacy of a new diagnostic device for assessment of oral health problems? What was the answer to that? So if you are an inventor or a researcher and your name is Janet, you invented a device, okay? A device that you're using scalers or cavitrons, right? For cleaning and prophylaxis, but you came up with a device. It's an innovative device that if you just scan the teeth with that specific wavelength that you have developed, all of the calculus, all of the plaque is removed just by scanning it with that specific wavelength that you have invented, right? It's really, really cool.
Yes.
Yes. And you're very proud of this, right? And you know it works. But it's only you that knows, right? Now you have to prove that this method is working, or even better, is the best method to use for dental cleaning. This would be innovative. What kind of design do you have to use to prove that this is the best method or is working
Compare it to other methods.
compared to other methods, right? So this is, question 8 is pretty much asking you, what design do you have to perform in terms of a clinical trial, right? That proves that this is really good. So then we are going back to standard of care. What's the standard of care for dental cleaning? What is the golden standard for dental cleaning?
Prevention.
For cleaning, just prevention is good, but once we have to treat the patient, what do you do for dental cleaning? What tools do you use? Ultrasonic, right? Cavitron. Pretty much the standard is hand instrumentation with the use of Cavitron. That's pretty much the golden standard for dental cleaning. So you're going to use a design that compares your innovative technique with a golden standard that has been in use in practice for a long time. So that's pretty much the clinical design that we are going to use to show that this method is working. So you have to think about the design, and it's pretty much comparing it to the golden standard. And I think question 8 here, the use of the golden standard, most of you were pretty much not aware of what is the golden standard or what's the meaning of the golden standard. So this is the pyramid that I was talking about, looking at the rank of evidence. And none of you have heard that, seen this pyramid before? Not really. Oh, that's interesting. So here, you can see the pyramid. What is at the very low end? Yes, it's background information that we see online in Google and expert opinion. What's this name? What's Dr. Oz, right? You know Dr. Oz? Ozzy? On TV, right? So those are expert opinions. right? He's an expert, he's a medical doctor, and he gives opinions all the time. He gives opinion on charcoal, he gives opinion on what food, exercise, everything. So those are expert opinions. So don't be misled, because those are really the lowest rank in terms of evidence. So when your patient comes back, and then you won't say that, oh, Dr. O said the charcoal is good, so you should do it. Then you're providing the lowest level of evidence to your patients. So you want to make sure that the evidence you're providing is up on the higher ladder at the pyramid. And then we have case control studies, case reports, which are very important, but still at the lower end we have cohort studies and randomized controlled trials. And these are all unfiltered information. So this comes directly from the expert or from the investigator. All of those are unfiltered. Here, going up, further up, you see the critical appraised individual articles. So some articles, such as a randomized controlled trial, could be filtered and reviewed by reviewers. Then it becomes filtered and the information becomes stronger, the evidence becomes stronger. Then we have critically appraised topics and systematic reviews. And one of the systematic reviews, which is on the highest end of evidence, are Cochrane reviews. What are Cochrane reviews? Cochrane reviews, they pull together all of the randomized controlled trials that have been performed on the same topic, and then they do an analysis of all the randomized controlled trials together and come up with a definite conclusion or recommendation. So those are Cochrane reviews and are at the highest end in terms of quality of evidence. And when you're looking for evidence, you should really look into the higher end to provide stronger evidence to your patients. So when you're performing evidence-based practice, we want to make sure that we go through all the steps that are associated with evidence-based practice. So what are the 5 steps for evidence-based practice to really carry out and implement evidence-based practice? First step. Yes, everything is it. So first you start with a question. The question might come from your patient. The question might come from yourself. You might think, oh, what is the best way to do this? Or I've heard so many things about this. Well, what is really the best way? Or it can come from your patients. And then you have to research, right? And find and locate the latest evidence. And then once you locate, it's not done, right? So you have to read and appraise and interpret those results to really digest and make sure that you make you're able to understand what is out there. And based on that, you will act, you will make a decision based on the evidence, and then after making that decision, you're going to evaluate whether it has been working for your patients. So you're going to evaluate, reflect on all of these results so that you can really get a better picture of what you're performing on a daily basis. So when I'm asking you during the midterm exam, what are the 5 steps to evaluate, 5 steps for evidence-based practice? What are you going to say? Yes, question, find, act, appraise, act, and evaluate. So this is a patient, this is very dark. This is a patient coming in with a diastema between the central incisors, and the patient is asking you. So my dentist recommended me to do a laminate veneer on this to close my space, because this space is really bothering me. I cannot speak well, and usually saliva comes out of my mouth, so it's really irritating me. So, but my dentist recommended me to do a porcelain laminate veneer to solve this problem. You have been my dental hygienist for such a long time, for 10 years. I really trust you. What do you think about this treatment plan? Bless you. So many patients will ask for your opinion about a treatment plan as well, right? You might not be providing that service to the patients, but your patients will ask a lot of questions. And this is Trisha.
I would probably recommend orthodontics instead if you want to be
Good. So Trisha would recommend orthodontics. What if your patient would say, yes, that's what my dentist told me, exactly that. But I don't want to go through these metal braces for 2 years. So the patient, so that's why you have to listen to your patient values, right? And their opinion as well. This patient didn't want to go through orthodontics. So now what?
Bridge.
What? Clear or metal? I don't want to go through ortho.
Bridge or crown.
Huh?
Bridge or crown.
Bridge or crown?
They don't need ortho. Smile Direct Club.
What's that?
Smile Direct Club. It's like Invisalign. that you
Invisalign.
just go to the middle.
Uh-huh.
Yeah.
Yes, but let's say this patient is very stubborn. Whether it's Invisalign, whether it's clear or metal brackets, I don't want to go through ortho. So if we rule out ortho, and once the patient says they don't want it, you just have to really think about other options that are available for that patient. Sandra.
Yes. I'll just tell them what's the disadvantage of having veneer in between, especially if it's a little bit big of a gap, and then they will decide if they still want to do it or
Okay.
to go with something else.
Good. So those are all scenarios pretty much that you will encounter during your daily practice, and you will have to do really a lot of research to be able to provide the best evidence and really help your patients in making the wise choices, because you are the ones that gives the options, right? Because not a single option is 100% correct. There are so many different options available. You are the one that have to be able to list all the options that are available and the disadvantages and advantages that come with each option. So when a patient would ask for a treatment option for this diastema, you could say, leave it alone, right? That's a choice. But the patient would not like it because it's irritating him. But you can still say, in order to preserve your tooth structure, no treatment would be a choice as well. Number 2, orthodontics, whether it's with Smile.com,
You never heard of it?
Invisalign.
It's like Invisalign.
Yes,
but it's called
Invisalign.
Smile Direct Club.
Yes, I have not heard about Smile Direct Club. I've heard about Invisalign. So either Invisalign or braces, just closing the space would be an option. And then number 3, now we have to look at restorative options, right? A big third category would be restorative options. And in terms of restorative options, you could do direct resin bonding. Doesn't have to be veneers. Direct resin bonding, porcelain laminate veneers, or crowns and bridges were mentioned. So all of those are options. But then you have to think about and do the research in terms of, let's say option 1 and option 2 is gone. Patient doesn't want it. Now you have to look into those restorative options and think about what is best for your patient. And when we do the research, a good way to start is finding the PICO. And the PICO question came up in a knowledge question as well, right? What is a PICO question? What question was that? Number what? Okay, which of the following statements best describes a PICO? That was question number 5. And when we are doing the literature search, we should really use PICO, which is a process of converting a clinical problem into questions that can be answered by searching for evidence. So PICO, what does PICO stand for? P, problem. I. This is good. Okay, let's switch.
Indicator.
So P, we have problem. I, we have what? Information. C, compare. Perfect. And O, observation. I love it. Okay. So PICO, we'll go back and come back with what PICO stands for. But even with this diastema, might be localized, can be multiple, right? All of those, if patients are asking you for advice, you will have to be able to research and look for that evidence. But when looking for evidence, it might sound very straightforward and easy. It's really challenging. It's challenging not only for students, it's also challenging for clinicians who have 10 or 20 years of experience. It's a challenging process. Why is it challenging? There has been a lot of articles on why this is challenging as well. Why is evidence-based practice so challenging? And why has it not been incorporated fully into our daily practice?
Because it's always changing.
Yes, because there's so much information. There is an overflow of information. It's being updated so frequently, so fast. It's very difficult to keep up with all the information. And then there are many different guidelines, right? This association comes up with this guideline. ADA comes with this guideline. CDHA comes with these guidelines. So there are so many guidelines that really are not in alignment. And then there are also patient-related barriers. Although you've looked into the literature and found that this is the best evidence, this is the best method to go, patient might just refuse to do it. And you come up with patient barriers. And then there are also barriers faced by yourself. Because sometimes, as clinicians, when you have experience of 20 or 30 years, you are not willing to embrace changes that come with technology or new methods. So there are a lot of barriers that hinder us to really perform evidence-based practice as is advised. So this coming back to the diastema closure. Let me show you this one. So this was an article where I showed step-by-step procedures of evidence-based practice in our treatment planning. And based on that, we answered the question of how to do evidence-based practice and inform the patient about best evidence in treating diastema. When you're treating a diastema with restorative procedures, what outcome would you expect? For what outcome would you look at? What would be an important factor for you to advise a patient? Longevity would be a good one to look to, right? If you have to make a choice between a direct resin-based composite, porcelain laminate veneers, and crowns, perhaps the best way to look would be to look whether the longevity of these procedures are similar or whether one is superior to another. So we did the search and found that in terms of longevity, direct resin-based composites or porcelain laminate veneers were pretty similar. But what is the advantage of direct resin composite? It's cheaper, economic, right? That's a very important aspect for patients. It's economic, and there is no need for tooth preparation. For porcelain laminate veneers, although it's minimal, we still have to really cut a little bit of the enamel to restore this with porcelain laminate veneers. But with direct resin composites, you build up this. Here is the build-up that I did on tooth number 8. You start with one side, close one side, and there was no tooth preparation associated with it. And then you continue and finish. This was right after treatment when I removed the retraction cords, and you can see it's a single visit, no tooth preparation, very economic. And another advantage, if this direct resin-based composite chips or falls out, what can you do? We just do it again or repair it. There is no loss of tooth structure, which is a main beauty of direct resin-based composites. So that's why we recommended our patients to perform a direct resin-based composite, and the patient was happy. So those are just, so once you treat, so we had a problem. What do we treat this patient with? And then we looked into the literature, right, and found the direct resin-based composite in terms of longevity is pretty much the same. And then we acted upon it. We did a we appraised the literature, right, acted upon it. And then after treating this patient, what do we do then? What's the last step? We follow up and evaluate whether this was a good choice after 5 years, after 10 years. So just finishing the treatment is not the end of our evidence-based practice cycle or routine. We really follow up on our patient and see whether this was a good choice. And that's the same with the multiple diastema patient that we had. And there are many, many questions that we can ask. So, does rubber dam compared to cotton roll isolation improve the performance of restorations? Those are questions that we can ask. And what we go for is really looking into the Cochrane library and look for the highest evidence first, whether there is a Cochrane review on this topic. And then we also go into the ADA website or the CDHA website and look for evidence to answer our questions. And here's the pyramid again. So we really want to make sure that we are looking at the highest evidence. And this is another pyramid. And this pyramid is important as well, because in order to get to the highest level, what do we need? Yes, we need all the background information. You cannot just have this highest evidence from the beginning. All the highest evidence is based on background information, expert opinion, case studies, clinical trials, and they go through the process of filtering to give us the best evidence. So don't discard. I don't mean to say to just discard and just ignore the baseline information. It's very valuable information, but you want to make sure you are able to filter it and appraise it properly so that you come up with stronger evidence. And as you go through the process of your junior and senior year, most of you learn by getting information from your teachers, from your mentors. But as you graduate, you will learn how to learn by yourself, get information by yourself, and be able to interpret the information properly. So in your reading assignments that have been posted, you will see different articles that have been recommended to become efficient in appraising the literature. And it starts with the PICO search, and then how to search for evidence for clinical decisions, understanding applying principle of evidence-based dentistry. So those are all good reading materials for you to become efficient and be able to appraise the literature properly. Most of the midterm exams questions will be based on how to search for evidence to inform clinical decisions, because you are pretty much looking for clinical decision-making processes. So at least I would suggest to read this one and understand and apply the principles of evidence-based dentistry. Those are two important articles that I would recommend you to read. So let's look at another clinical scenario. And I will have where's AJ? Huh?
He's in Alaska.
He's in Alaska? Oh, okay. And this is you're Jessica. Jessica, can you read the clinical scenario for us? Because it's Monday. I know you're all tired. And starting on a Monday with evidence-based practice is really tough. So let's wake up and let's listen to Jessica. You can hold this.
The surgeon explained the risk of post-operative infection after surgical extraction of mandibular third molars and gave the patient the option to use either chlorhexidine gel or chlorhexidine rinse. The patient asks you your opinion on the use of these two options.
Okay, good. So this is another clinical scenario. The patient went to the oral surgeon, and the oral surgeon recommended after the extraction, recommended to use either chlorhexidine rinse or chlorhexidine gel. And the patient is asking for your opinion. What would you recommend? Let's see, okay? So who would recommend chlorhexidine rinse? Let's raise our heads. Okay? Who would recommend chlorhexidine gel? A few. Who would recommend a placebo? Just use water. Nobody? Okay, good. So, and then who would say, I don't know? Who would say, I'm really not sure, about the difference between chlorhexidine rinse and the gel. So let me do some research and get back to you ASAP. So who would say that? Only 5? After this massive introduction about evidence-based practice? Okay. So,
I have another response.
yes.
Can you just say, could it just be like, what would you prefer? It could be your preference.
That's a good way to ask. But then you ask the patient.
If they both have the same effect,
Uh-huh.
will do the same kind of like same effect, like medicinal effect.
Uh-huh.
It could just be based on how well you rinse it palatably.
Mm-hmm. That's a good approach. But the patient, number one, wants to know. The patient does not have any preference, but wants your opinion and asks what is more effective, the rinse or the gel?
I don't know, I just think it's an extraction site, the gel would be better.
I think the rinse would be good
Why?
because they'll go into the pocket and then you could like swish and it's better about.
I originally said rinse, but actually with an extraction, we don't want to interfere with like the clotting. So
Mhm.
maybe the gel, if you're not like rinsing it around hard. I don't know.
Yes.
Can you tell us?
Yes,
Okay.
I would say, I think the best, when I encountered this problem, right, when I was asked this, I have to say, I really don't know. I mean, how can you know all of the information if you jump into conclusions based on what you have learned? That's dangerous as well, because you are just thinking about what you learned and you're not embracing changes in what is coming out in terms of new innovative ways and new treatment materials. You just say, rinse is what I learned, rinse is what I will do for my patients all the 30 years of my life. So that's not a good attitude. You really have to be able to embrace changes and also be curious about appraising new material. It's not that I say new materials are always better, that's dangerous as well. If you think everything that is coming out of the market is good, that's dangerous as well. So we have to find a balance and be able and willing to look into the literature. So that was a question that I would say I really don't know. So we have to go back and check what is in the literature out there. Because we know chlorhexidine rinse has been out for a long time. So that was a standard pretty much care for treatment of preventing dry sockets, to keep the wound area clean and make sure that it does not get contaminated. So that's pretty much standard care. But manufacturers came up with this new gel, which they call bioadhesive gel, and they claim that this gel is better in preventing dry sockets because we can place it into the socket, and this gel just releases slowly chlorhexidine to act on that socket area, whereas the rinse, it's just used one time or twice a day, just to wash off and act just for a short time. The bioadhesive gel, however, stays in the socket. It's a very light gel that you place there, and it will stay there and release chlorhexidine over a long time. So it sounds really good. Do you agree? After listening, it sounds good. But then still, we really need to go and look what the literature and evidence says, because all the information that we have currently, the knowledge is limited. So all of us have to go back to the literature. So now we are coming back to the PICO. And the PICO The P stands for population. So in this case, it would be patients that undergo third molar extraction. The I stands for intervention, and the intervention is the new intervention that we would like to test is the chlorhexidine gel. And you would like to compare it pretty much with the golden standard, which is chlorhexidine rinse. And we want to see how effective it is in preventing post-operative infection, dry socket, or alveolar osteitis. All are pretty much the same. And you would like to look at the outcome. So PICO is converting a problem into a clinical question that have 4 components, P, I, C, and O, to look for evidence. And you mentioned that you are looking into Google Scholar. The first place that I usually go is into PubMed. I'm looking for PubMed, and then I can enter all the different terms that I'm using. Third molar extraction, and chlorhexidine gel, and chlorhexidine rinse, and post-operative infection. And then I click search, and unfortunately it said, no items. There were no articles that had all these 4 components. So I'm changing a little bit. I say third molar, chlorhexidine gel, chlorhexidine rinse, and alveolar osteitis. And when I'm using a little bit of, when I'm changing my search terms, this gave me 4 results. And looking at the title of the results, look at this. Effectiveness of chlorhexidine gel versus chlorhexidine rinse in reducing alveolar osteitis in mandibular third molar surgery. This is really the one that I wanted to read. Do you agree? The other ones, they really a systematic review of chlorhexidine. It's really not that related to my clinical question, but this one, published in 2008, really addresses my question. So I'm really interested in reading this. So when reading this, you are not going to jump into the manuscript. You're first going to read the abstract first. And I will give you some time to use the restroom. And the others, you can read the abstract first, and we will continue in 5 minutes. Sounds good? So we'll continue at 9:10. And for those of you, just read the abstracts and we'll continue.
So this is right?
The same again. So you have to do that. does it?
Now you guys are all moaning that it's happening.
Yeah, they are.
Sorry, you have to do all of these work. It's just painful. Just my
Not those?
So basically the rinse is better. The rinse is better.
The rinse is better. What does it say?
That it may decrease the incidence.
No, but look, the rinse group had 25% incidence,
Yeah, for the gel only at 7.5.
had 7.5. 7.5. While the gel group had an incidence of 7.5 of alveolar uveitis, right? So it had less incidence,
Yeah.
right? So what does it say? What does it mean to
Well,
us?
yeah, so yeah, the gel's going to decrease more. But, it depends on patient education and whether they're going to apply it or not properly. Some patients
That's
just
correct.
put
That's
it on there
correct.
and they don't know if they're hitting the actual spot and can miss it. And the rinse, if you rinse, it can actually grab it all.
That's correct.
Because I got my wisdom tooth removed, and then he gave me a rinse.
I didn't know this was good. Oh, see, I thought it was one day. She posted an announcement. Yeah, I'm how's your weekend? Where'd you guys do your report? Marshfield?
It's at 9. The one I did have
She had to make sure I did the right things. So, okay. Did you upload? I did. And then Jessica. Excellent. Thank you.
It's not.
I was about to say.
I think the PowerPoint is better. The articles.
Really? I've been reading the articles.
All like reading.
Is that the copy?
Yeah.
This week.
These are airplanes.
Yes, and
Yeah, these are from the flight. I have them. How did you know? Yeah. I didn't And one has 8 and one has like 7.
Yeah, this one works on. Or this one.
You have to do that one at the top. And then you have to do it.
one of them. So, But see, I don't know
Which one it is?
It's a paper quiz.
But I can't remember.
I finished mine.
Everybody was like a scene to see the fireworks.
Yeah, I know. So I grew up going there. I was out there on Saturday. For my mom's birthday. Huh?
It wasn't until like the final six years of like
I don't know, I just kind of hope you guys like you for first like, I don't know, it's kind of
Okay, you ready for the second half?
Yeah.
Okay, so you all read the abstract, and based on the abstract, what does it tell you? What does it tell you? Just let's look at the results. The results show that the incidence for dry socket was 25% in the rinse group and 7.5% in the gel group, right? So basically this tells us, this article tells us that the application of bioadhesive chlorhexidine gel may decrease the incidence of dry socket after extraction of mandibular third molars. And just showing the numbers, it was really implying that it worked better than the rinse. But for us, this is just reading the abstract and reading the manuscript or the article. What you have to do is really appraise the article and interpret it to your daily practice to give good advice to your patients. So in order to appraise an article, we look into three components. We are looking at how serious the risk of bias is. So we have to evaluate the risk of bias. We have to look at the results and then have to think about how we can apply the results to our patient care. And when we are talking about the risk of bias, we are looking into whether the intervention, what was the intervention? The bioadhesive gel was the intervention. What was the control group? The chlorhexidine rinse was our control group. Whether both groups started with the same prognosis, right? We have to see whether the age, ethnicity, and everything was really balanced. If one group had only older patients and the other group had only younger patients, then you would say that the risk of bias starting at the beginning is good already. So all of those you have to take into consideration, and you want to make sure that the balance was maintained as the study progressed, and that the balance was still there at the completion of the study. So all of this risk from the beginning to the end has to be appraised by reading the article. So let's look at this. So usually in clinical trials, we randomize our population into 2, 3, or 4 groups based on how many interventions we are testing. So what are appropriate methods for generating the randomization sequence? Whether this patient goes into this intervention or whether this patient goes into the control group, what are good or appropriate methods for randomization? A, random number tables. B, coin tossing. C, all of the above. Let's raise our hands when you think it's C. 2 people, okay. Let's raise our hands when we think it's A. Let's raise our hands when it's B. What are those who didn't raise their hands at all? You have to make a decision. This is multiple choice, and this is something that I will ask during the midterm exam.
It could be both.
Yeah. Then you say C.
It's random.
All of the above, right? So the answer to this is C. Both. Coin tossing might seem a little bit primitive, but it's still an appropriate way for randomization as well as the random number table. So there are methods to properly randomize, and both of those are good methods to do a randomization. And that's what we pretty much use at the beginning, so that we make sure that the prognostic balance is there at the beginning. How to maintain balance during the process and on completion of the study is in the article about clinical decision making, and there will be questions on those in the exam. So please make sure you read it so that you're aware of how to make how to evaluate that the balance is maintained during and on completion of the study. When you're looking at the results, we want to make sure how large the treatment effect was and how precise the estimate was in terms of the treatment effect. When you look at the results that this article gave for chlorhexidine gel, the incidence for dry socket was 7.5%, and the incidence for chlorhexidine rinse was 25%. When we look at the relative risk, it's 0.3. You're having the stats classes with Dr. Oyoyo currently, right? When is your stats class? Tomorrow? What time? 8 to 10? Oh, that's a tough one. Monday, 8 o'clock. Tuesday, 8 o'clock. So, but Dr. Oyoyo talks about the statistical methods, appropriate methods, and he talks about distribution, right? Normal distribution. He might have already talked about confidence intervals. Did he? Not yet? Okay, that's okay. So let's look at this. The estimate most commonly used to assess the precision of the results is the confidence interval. A confidence interval is a plausible range of values within which the true value actually is likely to lie, given the data observed in the study. Right? So, in statistics, there's not just one single answer. We give a probability or a range that the results will lie within this confidence interval. The confidence interval, a 95% confidence interval range, means that if the study was performed 95 times, the result would be within this range 100 times. True or false? This is the definition of confidence interval. So what would you choose? A. Can you raise your hands if you would say A? Let's raise our hands when you think it's B. Okay? There's no C. So you really have to make your choice whether it's A or B. And the correct answer is B. It's false. The confidence interval or 95% confidence interval range means that if the study was performed 100 times, the result would be within this range 95 times. So it's a high chance. Out of 100 times that you're doing it, 95 times the results are within this confidence interval. So going back to this study, patients who receive the clohexidine gel have 0.3 times the risk of developing dry socket than patients who are receiving clohexidine mouth rinse. And the confidence interval that they had was 0.08 to 1.02. What does this mean to us? This confidence interval is very important, so that's why we're going to do this together. 0.08, and what does it say? Huh? 0.2? Oh, you don't have it. I removed it.
Maybe we can use the other marker.
.2. And what was the relative risk?
0.3.
So this is the 95% confidence interval of the gel, of reducing alveolar osteitis. This is the confidence interval. And what was the relative risk of the rinse to produce dry socket? The relative risk was 0.3, right? 0.3. Let's look at the numbers. 0.3. 1.02. 1.02. And this is the confidence interval for the gel. Where is the confidence where is 0.3 within the confidence interval? Huh? Is it outside or inside? Inside, right? So this is 1.02. So this is for the rinse, which means the risk, so we cannot really say which one is superior. The incidence was 7.5%. The incidence was 7.5 for the gel. And for the rinse, it was what? 25%, right? Just looking at the incidence, we might think, wow, the gel is much better, right? Because it's only 7.5% of incidence of having dry socket, correct? Are you with me? Right? So just looking at the results, we might think, wow, the gel is much better. I have to really advise this to my patient to use the gel rather than the rinse. But then when looking more closely at the confidence interval, we see that the risk of the rinse is pretty much within the confidence interval, which means that statistically, the rinse and the gel, when comparing the rinse and gel, there's no superiority of one or the other. So just reading the abstract might really create an impression that the gel is more effective, but when you look at the confidence interval, when you look closely, and that's the ability to interpret and appraise the article, you will find that you cannot really say that one is superior to each other. Both were good, had an effect in decreasing or preventing dry socket, but we cannot talk about superiority of one versus another. And when there is no superiority, what is important now to look at?
That's why I needed AJ.
Okay, so yes, Lucille.
I'm a little bit confused. When you're talking about the percentage, you're talking about incidences. That's like observed, like situations where
Observe where we had dry socket.
Okay. Now, the relative risk that's statistical, is that pulled from a bigger pool of
No.
information?
No, it's not pulled from a bigger portion of information. It's pulled from the results that we have. So we are looking at the relative risk. So when you're looking at the relative risk, this is the risk of patients to have dry socket when using the gel. And this is the risk of patients, right, that are using the rinse. It's 0.255. So this is the relative risk. 0.3 is the relative risk of gel, of rinse compared to the gel.
So let's just say if it was 0.7,
0.7.
yeah,
Uh-huh.
then the confidence,
It would be still within the confidence interval.
as long as it's below 1.2?
Let's say, just theoretically, that this would be, let's say it's 1.5.
Yeah.
Okay? Let's say it's 1.5. That means that the risk is beyond our confidence interval. Okay? So that would mean that the rinse was more effective,
Okay.
right? If it was, let's say it's 0.05, it's smaller, right? That would mean that the gel is more effective.
Okay.
But since both this falls into the confidence interval, it means that we cannot be conclusive in what is superior in terms of comparing those two treatment methods. Okay?
So then you would just go to patient's choice?
Yes, correct. So let's go further into looking at this. So the confidence interval of this relative risk ranged from 0.08 to 1.02. After looking at the numbers, now you have looked at the numbers, you conclude that even though the magnitude of the treatment, which is the incidence of dry socket, shows a large reduction in risk. These results are not precise enough to claim that the gel is more effective than the mouth rinse. True or false? True. Okay, so this is just to look a little bit more beyond than evaluating the results. We are not only taking the incidence or the reduction percentage in consideration, but we are looking at the confidence interval, which is the best way to look at an estimate of how likely there is a chance to have one observed incidence. So looking at these numbers, we think although the gel performed better, just in numbers, in terms of reduction, we cannot really claim that the gel is performing better. So now we looked at the results. Now you have to be able to apply these results. How do we apply these results? We are looking, were the study patients similar to my patients? You look at the patient pool, perhaps they just used patients that were in the 20 or 40 age range. Is this the patient pool that you are dealing with? I think you're looking a little bit with the elderly population, right? So you have to look whether the study patients were similar to my patients. Were all patient important outcomes considered? Are the likely treatment benefits worth the potential harm and cost? Because we know that the rinse is much cheaper than the gel. So all of these you have to now compare. And I think Daniel mentioned already during the break. You know, the gel, especially when we are dealing with a patient that doesn't have the dexterity to really place the gel exactly into the socket, then we are having problems. The patient that are using the gel, they have to be dexterous enough to really place it within the socket. And then costs, preferences of patient. So those are things that now we have to consider. And that's why evidence-based practice, as you mentioned at the beginning, has 3 components. Literature, evidence that is out there, patient's values, and your values as well. So we have to take into consideration those 3 big components to make the best decision. Was that helpful in really getting some clinical scenarios and how to look for evidence? So today I just went through just the steps that we have to do to appraise an article. So in order to appraise, we look at the bias of the article, we look at the results, and then we look at how we can apply these results to our patient pool. That's the way to appraise. Next week, Ms. Tamaris will come in and talk about what websites or what databases we have to look into to really locate good articles and good evidence. And during the midterm exam, which is on Monday, it's July 22nd, so it's coming up pretty fast. I will upload an article that you will read. And this is the questions that you will get. And this question, this manuscript evaluation criteria, I think is already uploaded, so you will have it available to look. But what I will ask is, you're going to read the article as is, and then pretty much answer those questions. What is the research question or hypothesis of this article? Does the research question address your PICO? What is the study intervention, duration, follow-up sample size? Did the results address the research question? And so those are the questions that you will answer. And then I will have selected questions from the midterm readings, posted on Canvas, so it will be multiple choice. And although it's multiple choice, you can go back to the readings that have been posted to look at what is the appropriate answer for this. So all the material you will be able, it's an open book that will be open pretty much for 1 week. I will post it on Monday. The site will close on Friday for you to upload this filled out form, and then it will be graded
You said this will be posted that week?
on Monday.
Okay.
On Monday, during the midterm exam. So the midterm exam week it's a little bit different from class to class. For this class, it will be on Monday, the 22nd, and on Monday 22nd there's no class. Your next class is the literature, where Ms. Tamaris will come in. So after that, so that's 15 next week. But on the 22nd, during the midterm exam, there's no class. There's no class, but I think around 7 o'clock or 8 a.m. in the morning, the article that you have to review and appraise, it's just to give you an exercise of how to properly appraise an article after reading, which gives you the step-by-step, because I have questions everywhere through the process. This will be posted on Monday in the morning, and you will have pretty much 1 week to complete and upload it on Friday. Any questions? Okay, so this is the midterm exam, and I will touch upon it a little bit next week as well. And today we will. Yes.
I just have a question. Are we gonna get this PowerPoint?
Yes, it will post. Usually I post it after the presentation. Last week's presentation has been posted as well. So after class, it will be posted. So the dental hygiene topics and mentors. I will give the sheet to Sabine, right? Today, because Sabine sent me the groups. She sent me 10 groups of 4 or 5 members. But after discussing with the dental hygiene faculty, we have only 8 mentors available, so 8 groups available. So you will have to reconfigure a little bit so that you make a group of 5 to accommodate the 8 groups that we have. And then I had some contacting me earlier that they would like to work with Ms. Hayton, so they are in that group already. But the other 7 groups are open, and most of them, so some faculty have their preferences in working with a specific topic. Some just say to be determined, to make sure that it is a topic that you're interested in, because I've heard also voices saying we would like to do a project that we are interested in. So you can discuss with your mentors and really change the direction of that topic. And even with Ms. Armstrong, or even with myself, with Dr. Cho, some of you might change by talking with your mentors. So after today, Sabine, can you work on this? And then I will send you the Excel spreadsheet so that you can write down the names. And then once it has been finalized, next week, once it has been finalized, I will post this on Canvas, the final version. And then you can start contacting your mentors and work with your mentors in looking for articles that are pertaining to this topic and starting to work on your research proposal. Okay, do we have any questions? Because I know that Dr. Cho has been working already with Lucille, right, on that project. So make sure that Lucille is on Dr. Cho's project and has members to work together. So please make sure to work with Sabine so that you have a working in a group that you would like to work with and work on a topic that you would like to work with as well. Any questions? Good? Okay. Thank you so much. Have a wonderful week. And I will see you next week.
Yes. Happy birthday to you. Happy birthday to you. Right? Like
Chorus, yeah, middle, but happy birthday. I don't think we skip like a happy birthday.